Hello, sir. Am I audible? Good evening. Hi, sir. Sir, you're not audible. I cannot hear, sir. No, sir. Not audible. Mm. Good evening, sir. Sir, can you speak? I will just ask few of the participants if they're able to hear you or if there is issue with my. Yes, yes, sir. Just I will ask. Okay. Okay. Sir, you are not audible, sir. Any issue, sir? I'll call you, sir.
Hello.
Yes, sir. You're audible, sir.
Right. So I have to remove this microphone.
Okay.
Maybe this is loud and clear.
Yes, sir. It's clear, sir.
Okay, fine.
Yes.
So I just see the chat box. Where is the chat box there?
Yes, sir. It's on the.
So
Just 1 second, sir. I'll make you the co-host, sir.
because usually there is a chat box there.
Yes, sir. It's if you can see below, sir, chat. There is a box, chat. Okay, if you click on that, it will open, sir.
Correct.
Yes.
So I just type that message there.
Yes, sir.
For the link.
Yes, sir. Sure.
There. So this is the link which is there reflected in the chat box.
So just click enter after you type, sir.
I have entered it. It is seen now in the chat box.
No, sir. I'm not able to see, sir.
Not there. Okay, I will put it.
Sir, if you just message me or mail me, sir, I will. Yes, sir. Now it is. Yeah. Yes, sir. Yes, sir.
So this is the link. Right. You can also see whether link is working. I just also click it to see that link is working. Yeah, I can see that link is working.
Yes, sir. It's working.
Right. So link is working.
Yes.
So right. So this part is fine. I just try to just see the now for PPT presentation.
Yes, sir. Yes, sir.
So I just check working or not. It is seen. Akshatha, is it seen?
Not exactly, sir. I can't see the slides. I just saw for a brief moment, sir. Now again it is not seen. Could you share again, sir?
It is in the share thing, and it is showing in the this thing. It is at present moment is not seeing. Okay, so I just put it again.
Yes, sir.
I just repeat the procedure. This thing is there.
Yes, sir. It is visible now, sir.
Visible?
Yes, sir.
Correct. I'm just putting it in the slideshow mode. Visible?
Yes, seconds. I think maybe net. Yes, sir. Visible.
Visible. So fine.
Yes.
So fine. There. So
could you change the slide, sir? We'll just see if that is. Yes, sir. Yes, sir. Perfect. Yes.
Correct. Correct. So you can request all the participants to just 5-10 minutes means this thing, whatever after introduction.
Yes, sir.
You can tell them to fill up this Google link form. Right. It is 15 MCQs question or otherwise. Right. So after that one I will start. So should I remove this stop?
Yes, sir. Stop sharing, sir.
Correct.
Yes, sir.
Correct.
Yes.
So at what time now? We still have 8 minutes.
Yes, sir. Yes, sir. We have
Yeah,
it.
we are in time.
Yes.
I just again see the slide because there is only the problem comes because here I can see two. So if this is there,
Yes, sir.
correct, it is coming,
Yes, sir. It's coming, sir. It's
right?
visible.
And then I will change it to slideshow,
Yes, sir.
and then it is in the
Yes.
this, correct?
Yes. Yes,
So
sir.
fine. So this is also tested.
Mm.
Audio, video is loud and clear.
Yes, sir.
Right. So this thing is there. So we are ready. It's all
Yes.
set. So I'm
Yes.
just stopping the video
Yes.
and putting on mode.
We'll just start exactly at 6 o'clock, sir. I'll introduce you, sir. Then I will again talk about this form. And then afterwards, you can start the
Right.
sessions. Yes.
Right. Right. Very good. Very good. Very good. So how are everything there?
Yes, sir. It's fine, sir. Currently.
Very good.
Mm.
Good.
Yes, sir. I welcome you all to the final day of the Fungal Diseases Awareness Week. So we are excited for all of you to join us today for the Fungal Infections 101. So as we wrap up this week-long journey, we have today's special focus on antifungal stewardship, a critical aspect of managing fungal infections. So today we have a distinguished speaker, Dr. Rakesh Singh. Sir, just a minute.
Yeah.
Yes. Just a minute, sir. I'm just sharing.
Hello. Good evening to all. And good evening, Dr. Akshatha.
Yes. So we have Professor Rakesh Singh. Sir is Professor and Head and the Department of Microbiology, JIPMER, as well as Director IATP ICWAS, President IAMM Puducherry Chapter. Apart from various awards and laurels, including Navopia, Dr. Pankaj Lakshmi V. Venugopal Prize for the Best Paper in Mycology. Sir has also received a Certificate of Excellence Award for achieving 5-star quality standard in HIV testing in ICTC and also travel right from Asia. He's author of multiple publications in national and international journal and has guided various MD and MSc students. Yes, including, and I'm one of the privileged student to have been guided by, worked under him and learned under him. I welcome you, sir, and my heartful regards for accepting and being a part of this webinar series, sir.
Yeah, thank you, Dr. Akshatha.
Yes.
And thank you also for giving me the opportunity to interact with all the participants and all this thing in the Fungal Infection Awareness Week. And one important topic which you have already chosen about the antifungal stewardship.
So I request all of you to fill the pre-test form. Sir has provided the Google form link in the chat section. If all of you, please let me know if everyone can access it. I request sir, how much time sir will give for that?
10 minutes we can give it.
Yes.
It is the 15 questions. It is related to the basically some of the case scenario which we might come across in day-to-day basis. These are the questions basically that this module, antifungal stewardship module, I designed it last year. And maybe if any participants who have listened to this session earlier may find it easier, may fill the form very quickly. And even it's a multiple choice question, so probably everyone can fill the form very quickly. But the thing is, it gives you very much understanding about the categorization of a patient into various categories, because my objective of the talk is to categorize the patient who is on antifungal stewardship to whether it is in the prophylactic category or empirical therapy category or preemptive therapy category or targeted therapy. So if we correctly identify it, then it is our job is easier, that we can shift from move from one category to another. That is our motive. And this is one of the bases of the antifungal stewardship. So that's why I request all the participants who are here, they fill the form, and then they can see that when in the presentation what is their response, and if they their responses can be modified. So that is all about this pre-test form. So we'll give it 10 minutes. So we will start exactly 6:15.
Yes.
So hopefully, because some of the joining may be late. So if in between the talk also, if they want, all the participants can keep filling the form. And so that we have the idea that how many participants and what is their thinking about it. I could not able to quote it directly, their responses there, but it gives me the idea about what is the general awareness and the understanding about this antifungal stewardship. Right? So all are requested to fill up the form. And by the time I just share the slide.
Yes.
So that we are if the slides are visible.
Yes, sir. Yes.
Oh, very good. Very good. So I request all the participants here to fill the form. This Google form, it is various different case scenarios and categorization of the patient into different categories. Now I think you can see that the slide which is showing the Google link form. Akshatha, the slide is changed.
Yes, sir. Slides have changed. Yes, sir.
Very
It's
good.
changed.
So it is working there. Perfectly all right.
क्लास में डालो वो बिल्कुल स्ट्रिक्ट भी है और मदर भी है और ये
How many participants are there at present moment? Suppose any number is there.
Yes, sir. Sir, we actually the limit of Zoom is 100, so we have full 100 participants here. We also have
Oh,
multiple.
my God.
Yes, sir. And we also have it's on live on YouTube, and we have around 25 participants in YouTube for now, which will increase.
Oh,
Yes.
okay. So approximately 125 participants at the present
Yes,
moment.
sir. Currently, sir, it will increase. Yes.
Okay, okay, okay.
So a few people are already
So
replying, submitted.
uh, at present moment, usually, I think I was told that it is 35 participants have submitted it.
Okay.
So approximately one third. So this is only 15 MCQs based question. All the participants are requested to submit this thing, which will give us a fair idea of what is the general perception and what is the understanding. Right. So we are now 6:11, so 4 minutes to go.
Yes,
I
sir.
request all the participants to fill up the Google form and submit it. It may be right, wrong, whatever is there, it's because it is a general understanding, certain concept. I may be having different concept and so it is a unique way of taking a session. Right, so 6:12, 3 more minutes to go. Fast, please. So it has just 50. 2 more minutes. Then we'll start the session. But I request all the participants to fill up the form because after filling the form and then we will see in the session, we will try to find out the answers for these questions in the sessions. Last minute, those who have not filled, I request all to fill it up. Right, all right. So approximately, so we have 6:15. So I request all the participants, so those who have not filled, they can fill it up. And by the time we will start the session there, and we'll try to find out the answers for these questions there. There, as I told previously, those who have joined late, I this thing is there. This module, I have developed it last year, and I have presented it 2 3 times there in different advanced mycology workshop, which we usually conducted here in Jipmer. And therefore, this module is basically to make you understand basically the patient to be classified between the prophylactic group or preemptive group or empirical group or therapeutic group. Because once we understand this thing there, then probably we can use antifungal stewardship, right? Yes, so probably here the slides, I think I just change the slide there. Right. So antifungal stewardship, we already are aware of the antimicrobial stewardship. Antifungal stewardship is a component of antimicrobial stewardship where you need to just change the word antibiotic and antibacterial drugs are replaced by the antifungal drugs. What is the goal there? The goal is only that optimal use of antifungal drugs or rational use of antifungal drugs. What do you mean by the rational use? It means, obviously, we know in the antimicrobial stewardship that right drug to be used, right dose, right route, and right duration. Even this, some of the Western data that it is not the Indian data, it is the Western data, they realize and they observe that 30 to 50% of the antifungal drugs can be reduced if they follow antifungal practices. So that is the quantum. So if you can imagine if Western countries can be able to reduce 50% of the antifungal drugs by utilizing antifungal stewardship program, then what could be the situation in India? It must be even huge than that one. And therefore, this thing is currently the time is there that we should also follow and practice antifungal stewardship. Now, the thing is, probably all of you are aware that antimicrobial stewardship is the need of a hour. Everything government is also putting full effort that antimicrobial stewardship should be followed. So why there is a need to introduce that antimicrobial stewardship? It is because that usually it is primarily bacterial centric and because of the MDR isolates, right? Because that usually if you see the organisms in the hospital, which causes hospital-acquired infection, they are resistant isolates, which cause the infection. And if the patient acquires the infection during the admission through the hospital, it is not a correct thing, and it is everyone agrees that it should not be there. It is as a healthcare person, it is our duty to make the hospital free from this bacteria. So we could not imagine a person who is admitted in a hospital for certain surgery, as for example, for certain surgery, and the person got infected with MDR isolate and results in the worst outcome. So therefore, as a healthcare worker, and it is our duty to make the hospital this organism free or MDR free, that minimize the hospital acquired infection into the hospital. So because one is the MDR, rise in the MDR, and we are having shortage of the drugs which are available to treat the patient. And second thing is because MDR isolates has a capability to spread inside the hospital. Because of these two things, we need the policy or the steps of the antimicrobial stewardship. But this was not the case in fungi. And if you look at the fungi 30 years ago, what is important is we are happy with the identification of just a candida. Not even, we don't want the name of a species. Even if we got to know that if something is, if the person is infected with fungal infection, that is good enough. Because, and we do not require antifungal stewardship because usually the isolates are not multi-drug resistant. And secondly, this even if it is resistant isolate, it does not spread in a hospital, just like multi-drug resistant bacterial isolates. Now you can see that when multi-drug resistant bacterial isolates, which is MRSA isolates, VRE, these are causing the problem and threat in a hospital. Now, another important thing that the resistant organism, which is prevalent in bacteria, why it is much more prevalent and not much prevalence is seen in fungi. One of the reason is because of the horizontal gene transfer. We know that in the bacteria that there is a mechanism of horizontal gene transfer in the form of conjugation, transformation, or transduction. But this mechanism is not seen, fortunately, at till date. It is not documented or demonstrated in fungi. So therefore, although the prevalence of resistant fungi is not seen, but MDR isolates is increased in fungi. So therefore, now if you look at the resistant isolate in fungi or fungus, that non-albicans candida, there is a rise in the resistance. And second important concern pathogen is the specialist fumigators. These are the concerned pathogens, which is causing the threat to the community or to the hospital. And usually, even earlier, it is only limited to the person. It usually does not spread in a hospital. But now, Candida auris, we all know that it is not only multi-drug resistant Candida auris, but it also spread in a hospital and causes hospital and pandemic status. And it is also associated with the high mortality. So therefore, because of this reason, because fungi are also coming up where it is multi-drug resistant, capable of spreading inside the hospital. So therefore, we also need the requirement of antifungal stewardship. Now, the first question which was asked is what is the most common antifungal drug which is used here usually? Why we should know that one? Usually it is the fluconazole, which is the most common drug which is used. The reason is because if we know that what is the most common antifungal drugs, so we can anticipate that this is the yeast or the fungi will develop most common resistance in that particular drug. That is the information if we know that one. So therefore, because the fluconazole is the most common antifungal drug which is used, so we can anticipate that the most common resistant or the highest resistant among the fungi in any fungi, mostly acquired resistant, I'm talking about the acquired resistant, is usually is seen in against the fluconazole. Now, if antifungal drugs, what is the use? We want to treat the fungal disease or to control the fungal infection. That is the purpose for any antibacterial drug or antibiotic drugs, to control the disease. So similarly, antifungal drugs is to control the fungal disease. But if we compare from the antibacterial drugs and the antifungal drugs are costly. Usually the antifungal treatment is comparatively of longer duration as compared to the antibiotic or antimicrobial therapy. And most importantly, it is also more toxic than the antibacterial drug. Why it is more toxic? The reason is very simple. Bacteria is prokaryotic and fungi are eukaryotic. Human cells are eukaryotic. So the drugs which are targeting against fungal cells, which is eukaryotic in nature, that will more, because human cells are eukaryotic, it's inherently more toxic than the antibacterial drug, because here it is it is prokaryotic in nature. So therefore, because here the problem is the treatment is costly, the duration is longer, and it is all toxic. So what we can anticipate is usually the compliance will be poor. So therefore, one of the important challenge which we might come across in antifungal therapy or treatment is the poor compliance. So whatever therapy which is advised to a patient, it is most of the time it may not be completed or may not be followed. Right, so we'll go to the first case scenario. Here we can see that the question is asked about a 54-year-old male admitted in ICU after his knee joint replacement surgery. He develops fever. Now, because he develops fever, usually the clinician has a tendency that the fever is developed, patient has developed the fever in the ICU, we want to give a prophylactic treatment. So prophylactic, we can take care of the bacteria, we can take care of the fungi. So therefore, the clinician is planning to start antibiotic and fluconazole. Now, in this situation, is fluconazole is recommended in this situation. Now, this the case where this thing is there, where our thing is to rationalize use of this thing. So here it is basically the thing empirical use, because the patient has developed fever, and then the empirically, I will come to this terminology and definition in the subsequent slides. But here the situation is the empirical treatment whenever is given to any patient, it highly dependent on the clinical skills of the clinicians. So clinical skills is tested in this situation, and also the knowledge, epidemiological knowledge. So we know usually that in an ICU setup, usually the first week, if there is, although the fever might develop because of infective, non-infective, even if it is in the infective cases, it is mostly in the first week, it is bacterial causes would be there. So in this situation, the antifungal drugs are not needed at all. So that is there. Antifungal drug, the situation could be if it is usually in ICU setup, usually fungal infection is seen if the patient is admitted for more than 2 weeks. So here it is ICU admission is less than 1 week. So it is epidemiologically also, it is primarily, even if it is an infective cause, it is the bacterial infection, not the fungal infection. Now that another case scenario, which is the second case scenario, which was shown there. And here, when the same patient admitted in ICU develops fever there, and here the patient does not respond to antibiotic, blood culture report shows Candida krusei, right? Usually, certain times it might happen that usually the laboratory gives the identification and AFST report. Usually takes some time. So this is one similar situation. They have informed the clinician that the blood culture grew Candida krusei. That immediately clinician thought that okay, Candida krusei is there. One fungus is there. Most common is fluconazole. So should we start this fluconazole? Is fluconazole recommended in this case? The answer is no. Why no? Because Candida fluconazole is not the right drug for Candida krusei. So we should know is about the intrinsic resistance. These are some fungi which is established, although the list may be longer and maybe keep on increasing it, but this is established. So Candida krusei is intrinsically resistant to fluconazole. So we should be aware about the intrinsic resistance. Right? Intrinsic resistance is absolute no for the treatment, right? So therefore, fluconazole is not the right drug in this case. So therefore, it should not be recommended. So similarly, for Cryptococcus species, echinocandin, Trichosporum species, echinocandin, rhodotronide, echinocandin, and fluconazole, these are intrinsic resistance, and therefore this should be not recommended in the treatment. So one thing is there, for anything, whatever is the organism, we should be aware of the intrinsic resistance there in that organism. That is quite useful. Now, the important thing, what is usually the message which I want to give it in this one, that correct identification of the patient in prophylactic, empirical, preemptive, and therapeutics. So we should understand the meaning, and the idea is whenever the patient or patient is given the antifungal drug, we should see that whether the patient is given in which category. We should classify this antifungal treatment in either prophylactic, empirical, and preemptive or therapeutic. And we should try to move the patient from one to another. If the patient is in prophylactic, then can it be made into empirical? Can from empirical to preemptive, preemptive to therapeutic. If it is in the therapeutic, then can it be de-escalated, and can the treatment be stopped? Antifungal treatment is stopped. So if we see and think over it, it is basically that we are rationalizing the antifungal treatment to each and every patient. Remember that each and every patient, the treatment is customized. It all depends on each and every patient. There are many factors which may affect or guide the treatment, right? So here now, what is the meaning of prophylactic? Prophylactic means to prevent infection. I'm sure all of you are aware of between the difference between infection and disease. Infection is carrying the organism, may be symptomatic, may not be symptomatic. So that is there to prevent infection, but disease means carrying the organism plus clinical sign and symptoms. Right. So similar, very good example is HIV infection. HIV infection means HIV virus is inside the body. So person can capable of transmitting the virus. That is HIV infection. But disease, usually it is the last stage of the HIV infection when person develop AIDS. That is the AIDS, and usually the manifestation is because of the decrease in immunity and because of the opportunistic infection which develops. So usually the manifestation of HIV is usually in the terms of AIDS. So that is the difference between infection and disease. And here the prophylactic means we do not want the infection. The first thing, the establishment of the organisms in the body, we do not want. So to prevent infection, so if we have to prevent infection, then we have to give treatment to all individuals in that one. But here, basically, to whom to give the prophylactic treatment? In high risk group, asymptomatic person. So these are the things. The person should be usually asymptomatic. So basically, we need to identify the high risk group where giving that antifungal drugs may be much more beneficial and than not giving it. So one of the classical example is maybe here children born from HIV positive mother, usually the cotrimoxazole prophylaxis is to prevent PCP. Right? It is of two types, primary and secondary prophylaxis. Primary is basically what I have already described, is to be given to before the infection, and the objective is to prevent the infection. Secondary prophylaxis means if the patient is on treatment, suppose antifungal drugs are given, the treatment, patient is cured of that infection, but the antifungal drugs are continued when the patient recovered from the disease, and it is continued for the purpose to prevent its recurrence. It is called secondary prophylaxis. So basically, it may be the prophylaxis means to prevent the infection, right? So it can be primary and secondary. Primary is even the exposure in a high risk asymptomatic person, we can give it. But secondary is probably the other one where it is after the treatment and we want to prevent the recurrence. So the key word for prophylaxis is to prevent the infection. Now, as I told, the empirical, the purpose is to treat early in high risk group and symptomatic person. So here the person must be symptomatic. Person should have sign and symptoms. Usually the most common sign and symptom patient develops the fever. So patient usually must be having fever at least. Right. So the first person is symptomatic, should also have some higher risk group, and here the purpose is to treat early. Here diagnosis is not confirmed. We could not diagnose. So it is basically the clinical skills. The most common example is the starting antibiotic in patient admitted in ICU who develops fever. So usually there is a tendency whenever patient is admitted in ICU, and as we saw in the previous one of the case scenario, the patient develops fever there, usually the clinician has a tendency to start antibiotic. And that is basically the empirical therapy. We have not confirmed the diagnosis. So it is basically highly dependent on the clinical skills. Apart from the clinical skills, we should also aware about the local epidemiology. So based on the local epidemiology, as we saw in the previous case, if ICU patient admitted in ICU develops fever in the first week, we primarily think that it may be primarily bacterial, not the fungal, and therefore antifungal is not recommended in that situation. Right. Now the preemptive. It is also similar to the empirical. Here again, the objective is the same, to treat early in high risk group. So it is similar to that one, if you saw that one, to treat early in high risk group, but here symptomatic. Here it is symptomatic and as well as asymptomatic. At present moment, you just keep it aside. So if it looks like very similar, to treat early in high risk group and symptomatic person. Right. So what is the difference between preemptive and the empirical therapy? Here again, diagnosis is not confirmed by the investigation, but here is some of the investigation are suggestive of infection. That is the difference. So as for example, in the previous case, ICU, a patient in ICU who develops fever, and if the antibiotic started, it is an empirical therapy. But if the antibiotic is started based on the procalcitonin, hypercalcitonin, CRP test, these are not the diagnostic tests for sepsis, right? But it may indicate that it may be patient might have there could be other reasons for increase in CRP or even procalcitonin. But the thing is, these are some of the investigation which may assist or guide or rationalize the treatment. So therefore, it is similar to that. Laboratory test guide rationality of the use of antimicrobial therapy. So preemptive is here again, diagnosis is not confirmed, but some of the investigation are suggestive. Whenever such situation is there, it becomes preemptive. So if the patient is on empirical therapy, we can look for, is there anything we can go for the diagnostic test. And so most of the time diagnosis is not confirmed. So because the diagnosis is not confirmed, then usually what is there, we can also go for preemptive investigations. And if the preemptive investigation can guide the antimicrobial or antifungal use, right? Now, therapeutic, or which is also known as targeted therapy, is to treat symptomatic. Here it is symptomatic. So all the three cases, it is symptomatic. Diagnosis is usually confirmed by the investigation. So clinical diagnosis is there. And apart from clinical diagnosis, here the laboratory diagnosis is also there. So this example, in the same case, ICU patient admitted in ICU develops fever. If the blood culture report is available, is giving the positive, and along with the antimicrobial susceptibility report, and the treatment is given as per that report, then it is basically the targeted therapy. So this is the difference between. Now I hope that I am clear about this four terminology, right? Prophylactic, empirical, preemptive, and therapeutic. So this is the summarizing of these four categories. Prophylactic, asymptomatic, right? So person is asymptomatic, high risk group, and here the objective is to prevent infection. In all three, probably it is all symptomatic, just leave about here preemptive, asymptomatic, right? But all three, empirical, preemptive, or therapeutic, it is all symptomatic, right? And in the first two, it is the objective is to treat early, and therapeutic, it is the objective is to treat, right? So here empirical is primarily clinical skill driven treatment. Here some investigation has suggestive of infection, so therefore it is laboratory assessed treatment. And therapeutic or targeted is basically laboratory confirmed treatment. So laboratory driven treatment, right? So empirical is clinical skill driven, therapeutic is laboratory driven, and here is preemptive is laboratory assisted, right? It is not confirmed, right? So that is there. Now, if we understood this terminology, let's recapitulate some of the case scenario, and let's see that one. What is the situation here? Now here it is asymptomatic HIV positive person, right? With a CD4 cell count, because whenever usually HIV positive person is there, they are sent to the ART for therapy. And they usually test for the CD4 cell count, and CD4 cell count come out to be 300 cells per millimeter cube. Now here they are planning to start cotrimoxazole. Now, is cotrimoxazole is recommended in this case? The person is asymptomatic, no symptoms, sign and symptom at all, and but cotrimoxazole is clinician is planning here, because now here if we know the situation, cotrimoxazole prophylaxis, it is a national policy, NACO guideline itself, that NACO prophylaxis should be given in two situations. One is all children born from HIV positive mother from 6 weeks to 5 years, and second, and second is all HIV positive person with CD4 count of less than 350. So because at this CD4 count, usually the individual is much more prone to develop this infection, and therefore the prophylaxis, cotrimoxazole prophylaxis is given to prevent pneumocystis jirovecii pneumonia, toxoplasmosis, bacterial pneumonia, nocardiosis, or cystoisosporiasis. So all these can be prevented just with the help of prophylaxis. And in this situation, we'll just wait for 5 years. After 5 years, this can be weaned off. And here, when the CD4 count moves more than 350. Usually, cotrimoxazole in adults, one is given in double strength tablets, a single day, right? Or alternative drug is the dapsone. So this is available there as a prophylaxis. Right. So other than cotrimoxazole, fluconazole is also recommended in situations like that one. Yes, as per our Indian guidelines, and we should be aware about this prophylaxis and when to give it. Right. So all the HIV positive person with CD4 count less than 100 cells should be given the fluconazole prophylaxis. And other indication, usually established indication for fluconazole prophylaxis is intestinal perforation, patient going liver transplantation, or pancreatic transplantation. Now let's see that one. Here, 54-year-old male admitted in ICU for 7 days, develops fever for 5 days. Patient is not responding to antibiotics. And normal culture report is pending. Right, clinician is planning to start fluconazole. It is similar to the earlier case. Now here, basically, is we know fluconazole should not be given because usually it is within the first week. Right. Now look at another situation. So here, the risk group here is ICU admission. Right, high risk group is ICU admission. Right. Now another case scenario where 54-year-old AML patient has admitted in the oncology ward for 7 days. The clinical case scenario is similar. He develops fever for 5 days with respond to antibiotics. Blood culture again here report is pending. Now here clinician wants to start the fluconazole. Now this thing, and one of the question which is asked is both the case scenario comes under which category? It comes under empirical category. Why empirical? Because diagnosis is not confirmed. Patient, there is a high risk group patient. One here is AML. The previous case is ICU. They develop, both are symptomatic, develops fever. And in both the case scenario, fluconazole is the clinician wants to start. Now the situation is here, it is empirical treatment, definitely. But again, as I told, that empirical therapy is highly clinical skill dependent, and it always depends on the case to case varies. Yeah, and apart from that, one is what is the epidemiology, right? In ICU, mostly, as I told, that in the first week, usually it is not, fever is not because of the fungal infection. So therefore, it is not indicated. So in this situation, here, it is not recommended, but it is a contrast case. Here, the risk group is AML. It is observed that AML patients are much more, or neutropenic patients are much more prone to develop fungal infection. So therefore, it is better. It is better to start if within 4 to 5 days, if the patient does not respond to the antibiotic, it is better to start antifungal drugs. So fluconazole is usually started by usually in most of the oncology ward, a patient admitted in those ward, AML patient or neutropenic patient, to prevent, to control basically usually because fever is there. So it indicates that infection is already there and it is the objective is to treat early here in this scenario. So it is a basically empirical therapy. Right. So just to again recapitulate those empirical therapy, it is a recommended in symptomatic high risk group. Right. So previous two groups we have seen ICU or the AML. Two are the contrast one risk group. One group where antifungal drug is recommended, but the another group antifungal drug is recommended in different situation. But at that case scenario, similar case scenario, it is not recommended. So it may be the initial part of the presentation. Whenever the patient goes to a clinician examines the patient, it is based on the clinical sign and symptoms. He or she, my clinician usually gives or prescribes antimicrobial drugs. So it is all comes under the empirical therapy only, right? So either investigation report are pending or it may not be confirmed report is not available or not feasible. Certain situations may be possible that the confirmed report is not feasible and that sample is difficult to take it. So we have to resort to the whatever the limited investigation available with us with based on that one treatment has to be given. So treatment is here basically in empirical therapy is based on the clinical diagnosis and it is basically the clinical skill-driven antifungal therapy. Right. As I told, oncology ward, it is usually recommended, usually that if the patient usually have fever and does not respond to the antibiotic, our 4 to 5 days on broad spectrum antibiotics, then usually earlier it was initiated that fluconazole usually is given, but usually because the most common infection in neutropenic patient is candidiasis. So therefore they started with the fluconazole, but they observed that that these patients start developing invasive aspergillosis. So therefore now usually the people usually preferred using the drug voriconazole, which can take care not only candida but also the aspergillus infection, invasive aspergillosis. So usually in that oncology ward patients, there if the patient is having fever for 4 to 5 days and does not respond to antibiotic, clinician usually immediately empirically start voriconazole. Now, for ICU, it is usually established that incidence of candidemia in ICU is 2%. So therefore, it is not recommended routine use of antifungal as empirical therapy in general ICU setting. So that is one is the most important things that ICU usually in that one, it is not usually seen as a general infection, but the risk ICU per se as a risk is less, but it may be added risk. So there may be possible that what is the added risk. So usually if we have that, what is the risk of candidemia with each risk factor, so we can add it and look for that one, whether we can make the matrix also if we have so much of data. So people are working on that aspect, or looking at the whatever the individual risk and whether this risk is applicable for giving as establishing the indication of the antifungal drug. So there could be added risk. So if there is added risk, so clinician might think of giving the antifungal drug. So it could be extremes of it, diabetic, one of the important factors, diabetes, high Apache score, liver dysfunction, or ICU stay more than 2 weeks. Right, as I told that ICU stay, if it is more than 2 weeks, it is there could be high chances that it may be a fungal infection can also be there. All of us are aware of the COVID pandemic, which is there. We have experienced first wave and second wave. There is a huge difference in the first wave and second wave. In the first wave, of COVID pandemic, usually we did not come across mucormycosis, right? But surprisingly, second COVID wave, there is a lot of patient come presented with COVID associated mucormycosis, or there is a huge means pandemic of mucormycosis in India, and there is a high mortality in the second wave. And I have also lost my relative, I'm sure, because it is such a bad time. And all of you might also have experienced that mortality of your means someone who is close to you in the second wave. And why it has happened that one, there is such a huge or drastic difference between the first wave and second wave. One of the important reason is in second wave, usually the COVID patient are treated with steroids, and steroids, basically we know that usually it also a risk factor for the development of mucormycosis. And second is usually India is a diabetic hub. There are much more cases of the diabetes patient there. Many patients are usually not aware of their diabetic status. So therefore, because these are the huge, diabetes is the huge risk factor. When COVID strain, one strain itself is different probably, but strain must have it also has precipitated diabetes. So there are multifactorial causes resulting in the precipitation of the diabetes, and results in these patients are develop much more prone to develop mucormycosis. So therefore, that at that time there was a very high mortality because the COVID associated mucormycosis. So later on, we are thinking that one is that the time where can we use posaconazole. Posaconazole is one of the good drug which can act on the mucormycosis. So can posaconazole, if we recommend posaconazole as a prophylactic, but prophylactic may be very difficult because whom to give, high risk group means all the diabetes patients should be give. So maybe all the diabetes patient at that time can be given it, or empirically maybe the situation, maybe some patient who are diabetic and develop the black ash scare. So without even investigation, they should be given posaconazole, could have reduced the mortality. So I'm just giving the situation where that intervention, the use of this intervention, maybe we can think of it. We can't test this now, but this is one of the situation where even this use of where to use the prophylactic empirical. This is a situation where we can use such type of antifungal prophylaxis or empirical use of antifungal drugs. So the idea is we should identify a particular high risk group, right? And giving the antifungal drugs in that high risk group should have a significant change in the outcome than not giving the drug. If we can establish those things, then it is very well reason to giving the drug as empirically or preemptively, as in the situation of AML cases or neutropenic patients, where voriconazole is recommended, right? So similarly, so this type of situation and indication, if we can establish, it will give a much more rationalized antifungal therapy in patients. Now coming to the preemptive. So preemptive, as I told, that some of the investigation might indicate that it is suggestive of fungal infection. So as I told, there should be some preemptive investigation. This you can also consider that usually for the postgraduate students that usually one of the common question comes as non-culture based test. So these are all the non-culture based tests, preemptive investigation, which might indicate, it does not confirm the diagnosis, but usually it might indicate that the fungal infection is present, right? So CT MRI, radiological, it will give us the extent of the disease, and usually because we are not associated with that one, so I can skip that CT scan part. there, but CT and radiological has a very important role in establishing the extent of the disease and even for the preemptive help in preemptive diagnosis of the invasive fungal disease. So here, other than that, beta-D-glucan assay usually very commonly used for even for invasive candidiasis. Galactomannan assay usually very commonly used for invasive aspergillosis. Mannan anti-mannan assay usually not much used because it is does not have a very good sensitivity. I have kept also, you might think that argue that why aspergillus and candida PCR is also included in the preemptive investigation. It is a confirmatory diagnosis. I will come to this thing later on. Right at present moment, we just see that these are the investigation. I have put also PCR in this list. Right. So if you look at this sensitivity, specificity, positive predictive value and negative predictive value, usually most of the test is in the range of 60 to 80% sensitivity. Specificity is more or less better, but the most important thing what we are getting is that these tests have a very high negative predictive value. So close to 95%. Right, all of them mostly, right? So one of the important conclusion what we can make it that if this test is performed, then rather than the positive report, negative report gives a much more useful information because it gives that one that maybe the antifungal drugs may not be needed in that particular patient. Right. Right. So usually the most common condition which we come across the candidemia, and if we ask that one, what is the test of choice? Blood culture is the test of choice. We also know that most important thing is the short turnaround time. So if we can reduce the short turnaround time, we can affect the outcome. Usually even with the best available investigation and even the treatment, the mortality goes to 40 to 50%. Now it is established that this mortality will be reduced to 11% if the antifungal treatment is started within 12 hours.
रखते हो मैं ही रखती हूँ रोज और जिस दिन मैं नहीं रखती वो ऐसे डाल जाती है मैंने सोचा दूध पड़ा हुआ है ये
Right. Okay. So it is right. So what is the best investigation in the case of candidemia? We all know usually the automated blood culture system coupled with MALDI-TOF-MS. MALDI-TOF has revolutionized the microbiological investigation. It identifies the culture isolates within half an hour to 1 hour. So it is a very revolutionized investigation technique. But the challenge here is still we are lacking behind the automated blood culture system, whether it is white egg, right? So still the sensitivity is 50 to 70%. And because of the white egg, usually the turnaround time is still 2 to 4 days. It is not the 12 hours. The need is 12 hours, but we still have a limited investigation. The automated building system along with the MALDI-TOF still, it usually goes to 2 days of turnaround time, and which is usually is delayed report basically for this situation. So what is the alternative? So therefore researchers are working on that one, and usually in Western countries now they have come up with the T2 candida that is also known as T2C. So blood T2C, how does it work? Is it works on the magnetic resonances combined with the molecular assay. So magnetic resonance and the molecular, basically it is one of the molecular tests. Here the sample is 3 to 4 ml of EDTA blood. So directly from the blood, the investigation can be performed and it can give rise to the result. Usually it detects, it has a limitation. The most 95% of the candidemia is caused by these 5. Usually Candida albicans, Tropicalis, Paracillosis, glabrata, and cruzi, right? But in India, usually the Candida auris is one of them. But in this panel, this Candida auris is not there. But in the Western countries, usually these are the 5 Candida species, and therefore now they are as one of the investigation. So apart from the blood culture system, they are using T2 Candida for investigation, and it has a sensitivity of 91% and specificity of 98%. What is the most important? It gives a turnaround time of 3 to 5 hours. So within 3 to 5 hours, which is the requirement, we will get to know that Candida patient is affected by candidemia or not. So therefore, in the America or the Europe, that the Western countries, they are also using T2 Candida for the diagnosis of one of the important investigation for the diagnosis of candidemia, right? So here the principle of this investigation is it lies the Candida cells by mechanical bead beating. So Candida cells is lysed, it releases the Candida DNA, which is amplified with the help of PCR. Then the amplified DNA, Candida DNA, is clustered around the magnetic nanoparticles. When it's clustered, it causes the change in the magnetic resonance, and which is usually detected by the system. So this is how T2C detects the candidemia, and the most importantly, it detects it within 3 hours. So basically 3 to 5 hours, which is very, very crucial, and therefore the patient can be initiated on antifungal treatment, and it may affect the outcome. It is a FDA approved investigation, and you can see that one each this, but it has a limitation that it can detect only these 5 common species: Tropicalis cruzi, albicans, clablet, and parasclerosis. Tropicalis cruzi, it can detect with the limitation of 1 colony forming unit per ml, while albicans and clablet are 2 and parasclerosis 3. Right. So this is it has got a 7 slot. And at any time, it does not require batch testing like ELISA test, where you can accumulate the sample and you perform the test in one batch. Here, as and when sample comes, we can load it into the equipment. The maximum loading capacity at present is the 7 slots, and it has always, just like any other assay, it also has an internal control to look for the invest. This is how the T2C equipment look like. So you can see that it is having the 7 slots there, and where the sample EDTA blood can just load into the cartridge, and the cartridge can be loaded into the equipment, and that's it. So it is a very simple technique, and anytime we can load any other. Suppose the sample comes after, so when the equipment is running, in between also another sample can be loaded into the equipment, and the 7 cabinets work separately, independent of each other. So this is how, therefore, this is the equipment which is very commonly used nowadays in the Western countries for the diagnosis of candidemia. The challenge was the Candida auris, so therefore they have developed a separate cartridge for the identification Candida auris, that is called T2 Candida auris panel. And here, apart from the blood, it can also work on the environmental or swabs, environmental skin swabs, which can detect the Candida auris. The limit is usually 5 CFU per ml. Sensitivity is 89%. They have a good sensitivity and specificity. But the importance of usually T2C is basically the rapid identification. The currently, which is usually in some hospital, the current investigation BioFire is available, but BioFire also works on only when the blood culture bottle is positive. It does not directly act on the blood culture blood sample. So therefore, that is a limitation. Right? So BioFire has a limitation. BioFire stem. So therefore, that for the candidemia, the rapid diagnosis of candidemia, the current best test which is available is T2C. So probably T2C may change the diagnostic scenario, and may help in the early detection of candidemia, and may affect the outcome if we treat antifungal drugs as early. So I have there in the list. Now again, as I see here, I have added here in the list of the preemptive investigation. Again, as I'm telling that one, it may be you might be thinking that why should I add in the preemptive investigation blood culture if it is Canada is diagnosed, then it is a confirmed diagnosis. I agree with you that it is a confirmed diagnosis, but there are two concerned pathogen. One is Candida, another is Aspergillus fumigatus. So for these two pathogens, we should also have antifungal susceptibility testing. If we do not have the antifungal susceptibility test report with us, so therefore, in my understanding, that one, it is not a targeted therapy. Right. So these two identify the organisms, but the limitation is that when the PCR, that is why the PCR I have kept it in the preemptive investigation. T2C is again one of the same way. It is the one of the PCR only molecular assay. So basically, but if they fail to provide the antifungal susceptibility report, so therefore, without that one. And because it is Candida and Aspergillus fumigatus, they are the concerned pathogen. So they should be at least should have antifungal susceptibility report should be available. Right. Right. So if we put it in this list of this thing, we can see that T2 Candida is all the parameters, sensitivity, specificity, positive predictive value, and negative predictive value, all are highest among all the things. So T2C is usually one of the preferred investigation. So along with culture for the diagnosis of candidemia, but other than candidemia, but in India, because this test at present moment is not available, so usually the candidemia is usually invasive candidiasis. This thing is basically the preemptive investigation, beta-D-glucan for invasive Aspergillus galactomannan. This is not much popular. They are very not much common there. PCR can also be used. So apart from PCR, this can be usually the preemptive investigation which can be used. So all this investigation can indicate that the person, this primarily the beta-D-glucan galactomannan. So this investigation, the preemptive investigation, are the investigation non-culture based assay, which usually comes as a question for PG student. So you can, apart from this test, you can add the microscopic investigation, which will complete the non-culture based assays for identification of antifungal disease. Now this case scenario. Right, so this is an AML patient, is in the oncology ward, develops fever of 5 days, does not respond to antibiotic. So empirically, these patients require antifungal drugs, right? So indication empirically it is there. But the beta-D-glucan was the investigation. So beta-D-glucan is one of the preemptive investigation. Report says 55 picogram per ml. Now clinician is planning to start fluprazole. Now here is that one, if you know the interpretation of the beta-D-glucan, this is the interpretation of the beta-D-glucan. So positive is more than 80 picogram, negative is less than 60 picogram per ml, and here in this situation, the beta-D-glucan says 55 picogram. So here, although empirically in this situation, the patient is recommended fluprazole, but preemptive, because the preemptive is saying that it does not require. So preemptive investigation indicate that this patient do not require antifungal drugs. So that is, we have seen that usually the beta-D-glucan, all these things have a very high negative predictive value. So therefore, based on that thing, it can be rationalized. So here, this beta-D-glucan investigation guided the use or not use of antifungal drugs, right? So here in this situation, it is not recommended. Now, another case scenario. Asymptomatic HIV positive, right? So whenever the HIV positive person comes in the ICTC diagnosed by HIV positive, they are sent to the ART clinic for the treatment, right? Right there, they will also, they test for the CD4 count, they will also test for some other, maybe tuberculosis is one of the investigation. So here cryptococcal antigen is also tested. Usually cryptococcal antigen, we in India, we are not doing it very common or routinely, but in African countries, it is very common and very routinely done in ART clinics, right? So once the cryptococcal antigen is tested, it comes out to positive. Patient is asymptomatic, cryptococcal antigen is positive. So clinician is planning to start fluconazole. Is fluconazole is recommended? Patient is asymptomatic. Should we start it? Yes, we should start it. It should be there. So it is one of the here. It is now the question is preemptive or empirical or prophylactic. If it is started, then which category it is? Right now, this thing here it is started because usually in tuberculosis, we know that if the patient is not treated with the infection, the patient usually, if the ART treatment is given, the patient might develop iris, right? So therefore, the patient should be usually cleared from these infections, and then the ART treatment should be started. So therefore, although here the patient is asymptomatic, the antigen test is positive, then here the patient should be given fluconazole or maybe antifungal drug, right? Now, this comes in which category? The question is this: is it empirical? No, patient is asymptomatic. So this category is preemptive, right? Preemptive. So this is an example of asymptomatic person, which is where that I told that you just keep it aside, preemptive antifungal therapy, where the antifungal therapy is indicated. That is the indication, asymptomatic person, which is just positive for the cryptococcal antigen. Now, suppose certain places, suppose cryptococcal antigen is not available, and usually the CD4 test is done, and CD4 count falls below 100, right? 100 or below. So at that time, if fluconazole is given, then it is a prophylactic, right? So here investigation is done. So cryptococcal antigen investigation is done, which will indicate the person is having infection. So therefore, it is a preemptive. But here, basically, if the cryptococcal antigen facility is not done, then because it is a high risk group, high HIV positive person with CD4 cell count less than 100 cells. So here it should be prophylactic treatment of fluconazole prophylaxis given. It is there, and it is also recommended by NACO. So if the CD4 cell is less than 100, then it is in India also it is better to test for cryptococcal antigen, right? Now, in this another case scenario where now patient is admitted to the ICU there, right? Where it is patient is sign and symptom of meningitis, cryptococcal antigen is positive. So clinician wants to start because antifungal drug we have usually newer drug usually in the form of candidate because usually earlier the usually clinician used to start with the fluconazole, then we usually clinician used to keep it amphotericin B for some of the difficult situations, and because of the candidate which is highly active against the fungus, and so therefore again here then this is a situation where the patient is admitted in ICU, cryptococcal antigen test is positive, so it is a diagnostic test because this is a test which the patient is thought of some meningitis, and if antigen is highly comes out to positive, so diagnosis is made of cryptococcal meningitis. Now here caspofungin is recommended in this case? The answer is no. Why no? Because although it is a very good drug, but Cryptococcus is intrinsically resistant. So it is not the correct drug for this infection. So because caspofungin is intrinsically resistant, so therefore it is here, caspofungin should not be given. Right. Let's go to the another scenario. A 54-year-old male shifted to the ward after knee replacement surgery. Now there, whether it is a respiratory sign and symptom is there or not, but usually that ball sample is given, ball sample grew kind of aerosolus, and which is sensitive to fluconazole. Right. So here again, clinician start fluconazole. So if clinician based on this thing, ball sample where kind of paracetamol is grown and it is sensitive to fluconazole. So this treatment, where do you want to fit it? Is it a prophylactic, empirical, preemptive, or therapeutic? Now here is what I want to say is basically the ball culture, the Candida, the presence of Candida in the ball sample. Is it a diagnostic investigation? That is this question is targeted about this thing, right? So usually the predictive value of Candida species in urine and respiratory sample. Remember that always there is a problem, respiratory and urine sample. It is very, very difficult. The predictive value of Candida species in urine and respiratory sample for invasive candidiasis is very low. So even if it is a ball sample, here it is a ball sample and Candida parapsilosis is isolated, means grown there. It is not a diagnostic investigation for pneumonia, right? We can't say that the patient here is suffering from pneumonia due to Candida. Because it is not a diagnostic investigation. Blood culture may give rise to Candida species, maybe because of it may contaminate sample, because ball sample can't be collected aseptically, and it invariably get contaminated with the upper respiratory flora, which may contain Candida. So therefore, the ball sample is 7. So similarly, the urine sample, it is very difficult to collect. Usually the midstream urine sample. So therefore, these two samples, the respiratory samples, it has a very low predictive value. It can't diagnose. What can only it will tell that it will enhance one of the risk factor for invasive candidiasis. So therefore, if the patient, if here the clinician wants to start antifungal, it is not that one. It comes under therapeutic category because it does, this investigation is only empirical. It gives a increase in the risk factor of development of the invasive candidiasis. So therefore, this comes in the category of empirical therapy. Suppose a radiological investigation also assists for the this pneumonia, that their CT MRI suggests that the patient is suffering from pneumonia and ball sample grew Candida parapsilosis, then probably it may be the preemptive, because some of them CT MRI is suggestive of the infection, corresponding infection, right? For therapeutic, then it should be that tissue biopsy. So lung biopsy sample should demonstrate the presence of Candida in the biopsy sample. Usually it is difficult. That is what some of the samples are so invasive that we usually do not do. So that is the limitation. So that is there. So here this thing is this question was meant basically to make aware that the presence, although you might see come across Candida in ball and urine sample, but these are not the diagnostic investigation, and most of the time, usually even we do not even stop writing or reporting the Candida species in the ball and urine sample, because invariably, if it goes to the clinician, they usually start antifungal drugs. So remember that there the predictive value is very less, and they will not, it is not a diagnostic test. The presence will just include one of the risk factor, and therefore, if the clinician, because the decision is with the clinician, the clinician still wants to start antifungal drugs in substitution, it is basically in the empirical category or preemptive, not the therapeutic category. Right. So here, now this is a situation there. That patient admitted in the ICU, it develops fever, blood culture report is pending. So, as I told, in Western countries, they will do both blood culture as well as T2C. So, T2C basically, or you can see that there is a in India, there may be that PCR is also done. So, PCR is detected Canada, and it is Canada Glabrata. We get to know Canada Glabrata. Now, clinician wants to start fluconazole. Now, fluconazole is recommended in this case. Now, the situation here is right. So there we should know that Canada Glabrata. So Canada Glabrata and Cruzi is intensively resistant, but Canada Glabrata has a reduced susceptibility against fluconazole. So therefore, if we get to know about the Canada Glabrata as a cause of the infection, then usually this is the patient is admitted in the ICU. So fluconazole is again not the correct drug in this situation. Here, a kind of usually is the drug of choice. Now here, this situation, the blood culture where the PCR, as I told, that one has group and Glabrata. So it is one of the diagnostic tests, right? But this test does not give a AFST report. So this test is usually incomplete to categorize this treatment into therapeutic. So therefore, although it is one of the tests which will confirm the diagnosis, but it is incomplete. And at least for these two pathogens, Candida and Aspergillus, Aspergillus fumigatus, specifically, even not all Aspergillus. Aspergillus fumigatus, if it is there, it is always recommended. It will always better that we should have the antifungal susceptibility report. Then only it will become fulfill the criteria of therapeutic treatment. Right. So we'll go. This is probably another scenario, which may be the similar one. Diabetic male admitted in the emergency ward, and we can see the black scar on the palate. And tissue sample is collected from that one, and microscopy KOS shows broad aspected hyphae. So broad aspected hyphae, then the clinician started emergency B. So what is this category here? The treatment category, is it prophylactic, empirical, preemptive, therapeutic? So here, basically, even it is a microscopy, it is not, there is a mucor which is there. And although we do not have this thing, AFST report, but still, because at present moment, maybe later on, maybe it may be possible that mucor may also comes in a cause of concerned pathogen. If it comes in a concerned pathogen, then we should have also the AFST report before categorizing it into the therapeutic. But at present moment, usually the consensus is concerned pathogen is usually the Candida species and Aspergillus fumigatus. So therefore, even if this is a microscopy without AFST, it confirms the case of a mucormycosis, and clinician is starting that antifungal B, so it comes in the category of therapeutic. Right. So that's why that is the therapeutic antifungal therapy in terms of the fungus. We can categorize that one if the microscopy shows broad accepted hyphae, which is suggestive of mucormycosis. India ink is positive, or critical antigen test is positive, which is suggestive of cryptococcosis. Right. But in case of Candida species and Aspergillus fumigatus, which are the concerned pathogen, here the targeted or therapeutic therapy is only established if we have the AFST report. So therefore, it also encourages that lab should also establish the AFST report for the Candida species. At present moment, most of the lab have started for the Candida species, but now we should also gear up for that AFST report for the Aspergillus fumigators. So we should also work on those aspects, right? Because this is the demand of the time, and probably it might be possible that in future maybe mucor also comes in the list of the concerned pathogen. Then probably we may also look for the AFST, or the clinician also usually demand for the AFST report of mucor species. Usually, whenever we are talking about the NABL accreditation, there is a very concerned thing, clinical alert value. So here I have tabulated the clinical alert values in the case of fungus. One is the very important, the broad accepted hyphae, which is in the QH microscope ABC. It is a suggestive microsis. We should immediately alert the clinician. So the idea of clinical alert value is to the lab person. It is the duty of the lab person to immediately alert the clinician so that treatment should be started, and it will usually about the outcome of the intervention. So mucormycosis, broad presence of broad accepted hyphae in QH, or as I told, cryptococcosis, India positive, cryptococcal antigen positive. This should be immediately communicated. Or even that blood culture bottle flag positive, and we can perform the gram stain, because as I told that candemia, the time is very crucial. The turnaround time is very, very crucial. The blood culture bottle flag gram stain can be performed, and the gram stain shows this cell. It is the suggestive of candemia. Then again, it is one of the alert value. We should inform the clinician. They can start the antifungal drugs. And similarly, sterile body fluids, if shows the ground chain shows yeast cells or QH shows fungal elements, then it is again suggestive of fungal disease, and this should be informed. So these are all the clinical alert value. As a lab persons, we should, whenever we are seeing that one, we should immediately inform to the clinician so that intervention is done, and it may affect in the outcome of the patients. Right. So what are the concerned pathogens? I told that Candida and Aspergillus fumigators are the concerned pathogens. So invasive candidiasis, we should monitor the prevalence in the hospital based. Some of the data usually we should monitor. So invasive candidiasis, invasive aspergillosis, Candida auris, as I told in the beginning slide itself, it is a multi-drug resistant and capable of transmitting within the hospital, causing hospital pandemic there, and difficult to remove out of the hospital. So therefore, it is very crucial to look for the Candida auris and monitor that incidence or prevalence in a hospital. And so because Aspergillus fumigators are the important pathogen, concerned pathogen, so their antifungal susceptibility profile is crucial. So AFST profile of Candida species as well as the Aspergillus fumigator should be monitored, which will give rise some guidance that what drug should be used, because as I told earlier, the empirical treatment, apart from the clinical scale, it also important to have the local epidemiology. So if we generate the hospital-based data there, which will guide that empirical treatment in high-risk group, and therefore it can guide that one which particular antifungal drug should be used. Right. So in antimicrobial stewardship, all of you must have learned about the parameters. So just like mortality is one of the parameter, length of stay. So similar parameter also same thing, because it is also the same thing. It can also be applied here to look for that the effect of the program, antifungal stewardship program, but particularly if we related to that one fungal related aspect parameters, then one of the important parameter could be time to start antifungal therapy. So what time we have to make that one, establish that one at the earliest, what is the earliest one, how we can decrease the initiation of antifungal therapy in the indicated cases. As I told in the case of, in this session, in the case of candidemia, which is important clinical conditions. Right. So And once it is there, what is the duration and what is the outcome? Means how long it should be used for that duration. So antifungal drug consumption, right? If too much of empirical therapy may increase the antifungal drug consumption and antifungal, then it might increase the resistance. So therefore, it has to be rationalized, used, and rationalization comes if we can put each patient into each treatment as a but patient specific treatment and categorize the patient into these particular groups and try to think over it whether can it be shifted from prophylactic to empirical, or to can it be de-escalate the antifungal therapy, or we can be stop the antifungal therapy, right? So occurrence of the recurrent or breakthrough infection. So suppose the patient is on empirical therapy or prophylactic therapy, but still the patient develops, that is called the breakthrough infection. So how many such cases happening into a in a area or a hospital? These are some of the fungal specific parameters which can monitor, which can be monitored, and we just look for that indices which can look for the antifungal stewardship program activity. So just to summarize, antimicrobial stewardship program is already started. It is now in most of the hospital. It is full-fledged. Government of India is after that one. So administrative commitment is there. Hospital side also they are working on in this aspect, and it is primarily bacterial specific. It is also high time to start the antifungal stewardship program. So this is because fungal, that's why the Fungal Infection Awareness Week was meant for that all are to make aware about the fungal infection. This is also there. There are some of the infection which may look apparently silent, as one of the infection is mucormycosis. We saw it in the second COVID epidemic, how it it converted the COVID pandemic into very high mortality. So similarly, the cause of the mortality in most of the cases may be related to fungus. So it is high time to also start antifungal stewardship program. It is nothing but to integrate antifungal stewardship with the antimicrobial stewardship program. So basically that one is there. In antimicrobial stewardship program also, just we include the antifungal stewardship, and we just think of rationalized use of antifungal drugs in the healthcare system, right? Any patient who is put on antifungal drugs, if we can able to categorize it to the prophylactic, empirical, preemptive, and therapeutic. So in this session, I took much time to narrate about this terminology with the help of various case scenario. And our motive is, if the patient is on prophylactic treatment, so can it be made into empirical one? If empirical, then can it be preemptive? So some of the preemptive investigation may assist in guiding that one, whether antifungal drug is used, should be used, or should not be used. If it is preemptive, then try to make a confirmatory diagnosis. If it is confirmed diagnosis is made, then it rationalize the use of the antifungal drug. And then after the course of the treatment, we should look for the, if it is empirical or preemptive, we should try to de-escalate it. And our motive is if to stop the antifungal therapy without affecting the outcome. So ultimately, goal is to optimize use of antifungal drugs or rational use of antifungal drugs. That is the basic fundamental principle against the antifungal stewardship program. With that one, thank you very much, and I hope that you must have got the answers for those questions or the pre-test.
Thank you, sir.
Thank you very much.
Yes, sir. It was a wonderful session clearing the most important concepts in the anti-fungal stewardship. Sir, there are good comments, all the like people liking the presentation even on YouTube, sir.
Oh, my pleasure.
If there are any questions, you can unmute yourself and ask, or you can leave it in the chat box. Currently, there are no questions. Sir.
Oh, excellent. Then probably that one, probably they might have understood it. Probably.
So you have made it really very clear, crystal clear.
Right. So this is basically, as I told, this module is very unique module. You won't find this module in any of the platform. This I developed it. We basically sitting on the basic all the case scenario. Then I thought of this: what is the basic problem which comes across it, and what is the basic about antifungal stewardship, what we can do about it. So that is all, and based on that one, various treatment. So this module basically help in identifying and clears the principle of antifungal stewardship, and we should start using it in the clinical case scenarios. And definitely our outcome is now look for the parameters. At present moment, antifungal stewardship parameters are not there. If I look at we are not working on that aspect. So we should start working on this aspect. So in this fungal infection awareness week, because if I think that there are 125 participants are there, even if 5 to 10 participants, they start working on antifungal stewardship parameters, I will be much more happy. And that when real, it will change our the fungal infection, the vision and use. Definitely it has an effect on the use of antifungal drugs in our community, in the hospital. And once it is rationalized use is there, definitely it will affect the resistance in the fungus.
Yes. So I see one question, sir.
Yeah.
Sir, is there any timeline for duration of therapy for empiric, preemptive, prophylactic regarding the antifungal?
Right. So prophylactic treatment usually always have the timeline in the terms of, if you see the prophylactic one is cotrimoxazole for the primary prophylaxis, as I told that one, the HIV positive, the children born from HIV positive mother, the prophylaxis should be started with the 6 weeks of the age till 5 years. That is there. Or the CD4 count, if it is falls below 350, because this is the risk factor, then we need to check whether CD4 count attains 350 and it remains 350 for at least 6 months. Right? So that is there. So the risk factor which is triggering the antifungal use should be removed and it should be sustained. Once we establish that, then we can remove that antifungal drug. So similarly, in empirical therapy or with their empirical therapy is basically clinical based. So we should look for the clinical signs and symptoms. As the patient recovers, usually, then clinician usually stop the treatment. That is empirical. In preemptive, usually it is investigation based. Certain investigation is guiding. As for example, beta-D-glucan. So usually recommendation is beta-D-glucan assay should be done twice in a week. So if we in India, we can't do it twice in a week, we can at least do it once in a week. We can monitor the trend of the beta-D-glucan levels, because if the patient is responding, the beta-glucan level falls below. It shows a decreasing trend. Right. Once it becomes negative and it sustains, then we can stop the antifungal therapy there. So this is although the understanding is what is triggering the antifungal drugs.
Yes, sir. So there is another question. When AFST is available for crypto, why call positive cryptococcal antigen or India in therapeutic rather than preemptive, sir?
Right. So that is what is I have told that we should know our concerned pathogen. At present moment in our community or in India, The concerned pathogen is Candida species and Aspergillus fumigatus. These are established ones because these are having at a high prevalence. There the resistance is high, and therefore, because there the resistance is high, it is categorized as the concerned pathogens. So once it is categorized in the concerned pathogen, then we can assume that if there is a Candida species, the antifungal susceptibility pattern, it may be resistant, may be susceptible. Right. So similar situation, I will put you in 30 years ago. Candida species at that time, usually most of the species are susceptible. So that is not the concerned pathogen. So if you know even the Candida species, that is good enough. Nobody is bothered about to identify the species, or nobody bothered about to do the AFST report. But now the current situation is, it is a concerned pathogen, meaning thereby that resistance is develops in Candida species is sufficiently high that in many cases it may not respond. Right. So therefore, when we categorize it as a concerned pathogen, then it means the therapeutic should be once AFST for that pathogen is available. Now, Cryptococcus species at present moment is not the concerned pathogen. So mostly even whatever the treatment option, which usually at present moment, when cryptococcal meningitis is there, usually we start with amphotericin B and fluclocytosine. So usually most of the time, even if we do not have that AFST report, usually the cryptococcal meningitis case will respond to this treatment. Once suppose if this Cryptococcus, the resistance will start developing it, and resistance is significantly high, maybe usually we consider it as at least more than 10%. If it is more than 10%, it comes into the category of concerned pathogen, and then it becomes a mandatory thing to have at least AFST before, means also to guide the treatment. So that is the difference. I hope that I have answered the question.
Yes, sir. So there is one question on YouTube. Sir, in case of non-albicans Candida species, is it necessary that we should treat them on par with albicans Candida species with respect to antifungal drugs?
No, obviously not. In one of the situation, if you have seen that one Candida glabrata case, Candida albicans and tropicalis in India also is still much more susceptible to fluconazole, but parapsilosis, glabrata, and cruci is intrinsically resistant. So parapsilosis and glabrata are usually having higher resistance for fluconazole. So it should not be treated as par with Candida albicans. And that's why for usually, if the patient is nice, you usually clinician usually, and we also recommend that that drug of choice for them is a kind of hendrin rather than the fluconazole or amphotericin B. So they should not be treated as par.
Yes, sir. Currently, I think all the questions have been answered, sir. I thank you once again, sir, for making time and having such a wonderful presentation here, sir. And taking time from your busy schedule to do the same, and for agreeing at such a short notice, sir.
Thank you. Thank you so much.
Yes, sir.
And thank you for all the participants here. And I wish that this session might be useful, and you can make use of this session for future. Thank you all.
So this is another, yeah. Thank you, sir, again. This brings us to the end of the seminar webinar today. And with that, we end the series on Fungal Infections 101, which was organized as a part of the Fungal Diseases Awareness Week. And one more reminder for Aspicon, we at the end of this month we have Aspicon. So this time for the virtual participants we have the quiz, and also all the delegates of the Aspicon will be getting free 6-month subscription charge subscription for the Sanford Guide, which is a very excellent app for your stewardship perspective. Also, what is next on my YouTube channel? So we have the fast therapy series where we have the Professor Gopal Nath sir from BHU University, who is actively involved in working with the FARJ, and whether fast therapy, is it really a myth or a reality? We'll be hearing from the expert himself. I'll be announcing the date shortly, so stay tuned. Yes, sir. With that, I think we can end it, sir. Thank you.
Yeah, thank you so much. Thank you so much all. And if there is any question, if it comes to you also, they can write to me also, or they can, if it comes to you, you can also direct to me
Yes.
at any time. Thank you all.